Now we come to the last speaker, Professor Ahmed Khairy University. The lecture will be popliteal artery trifurcation aneurysm. What will be the next?
Good morning. I'd like to thank the organizing committee for kind invitation to be a part of this elegant conference. My presentation will be about popliteal artery trifurcation aneurysm in multiple aneurysm syndrome. What was before and what will be the next? Aneurysmal disease in young patients is uncommon. Most cases are associated with underlying causes such as trauma, infection, connective tissue disorders, or arthritis. Multiple arterial aneurysms are even more uncommon. In most cases involve one part of the arterial system. It may be affect renal, mesenteric arteries are involved in most cases. Lower limb, carotid, and intracranial arteries are involved in less than half of the cases. Popliteal artery aneurysm are the most common peripheral arterial aneurysm. Among asymptomatic patients, popliteal artery aneurysm in 14 to 24% will become symptomatic within 1 to 2 years, and 31% to 69%, 68% will develop complications during patient lifetimes. Thrombosis of popliteal artery aneurysm didn't correlate with the aneurysm size. My case is 32 years old male patient presented with right lower extremity Bluetooth syndrome and acute onset of wrist pain. Patient initially had been diagnosed 8 years ago with right popliteal artery trifurcation aneurysm that was managed conservatively with follow-up and prophylactic anticoagulation therapy due to the aneurysm size. Also, patient had history of several arterial aneurysm disease. Initial duplex revealed anterior tibial artery aneurysm size 7 by 4 by 4 centimeter, tibioperoneal trunk aneurysm 7 by 4 by 3 centimeter with partial thrombosis. Diagnostic CT angiogram shows that trilobular right popliteal artery trifurcation aneurysm with thrombosed proximal origin of posterior tibial artery, chronic thrombosed left popliteal artery aneurysm. So surgical repair was decided. My strategy includes 3 key points. Surgical exploration of anterior tibial artery to achieve distal control, exposure of popliteal artery and tibioperoneal bifurcation through medial approach. After achieving a dissection of the aneurysm, I avoid extensive dissection to avoid injury of popliteal vein. I attack the aneurysm within inside and control both posterior tibial and peroneal artery within inside by using Fogarty caster. Repair was done with reversed saphenous graft, revascularizing both posterior tibial and peroneal artery, ligation of anterior tibial artery with an eventful post-operative event. And this is the post-operative 3 months CT angiogram shows that good for revascularized lower limb with patent peroneal and posterior tibial artery. What was before? The story started 8 years earlier in 2016. Patient was diagnosed having right brachial artery aneurysm as presenting with pulsatile non-traumatic antecubital fossa swelling, and investigation revealed that brachial artery bifurcation aneurysm sizing about 4 centimeters. Surgical repair was done using antecubital cephalic vein in reversed fashion. After treatment, whole vessel CT angiogram was ordered to investigate or explore other territories, and normal cerebrovascular circulation confirmed. Right renal artery aneurysm, left common iliac artery bifurcation aneurysm, left inferior gluteal artery, right inferior gluteal artery aneurysm, right deep femoral artery aneurysm, left SFA multiple aneurysm, and right popliteal artery trifurcation and chronic thrombosed left popliteal artery aneurysm as we see in the images. What happened on 2019? Patient presented with left-sided deep-seated pelvic pain of unexplained cause like sciatica after investigation and excluding other neurological case, and on half grade of suspicion with proper knowing the history of the patient, CT angiogram ordered that shows that leaking left common iliac bifurcation aneurysm comprising sciatic nerve, and also, unfortunately, they increased the size of right renal aneurysm up to 5 centimeters. So, decision was taken to do intervention. Endovascular simultaneous repair of renal artery aneurysm and leaking iliac artery aneurysm with covered stent was done. This is after exclusion of the right renal artery aneurysm, and repair of the bifurcation aneurysm with technique what we called covered endovascular repair of iliac bifurcation, what like CRAB technique, using a covered stent for common iliac and 2 covered stent, 1 for internal and 1 for external. And here, this is the leaked aneurysm. And finally, the angiogram, total exclusion of the aneurysm was achieved. And this is 4 years follow-up CT angiogram of the patient on 2024, revealing that total patent repair of the iliac vessels, and also patent covered stent of the renal artery, and see the right inferior gluteal multiple aneurysm here. And this is also follow-up CT angiogram, total patent external and internal iliac artery branches. What will be the next? I think these will answer this question. What aneurysm will be symptomatic, right inferior gluteal or left femoral artery multiple aneurysm, or left SFA aneurysm. I think these will reveal that. My conclusion, challenges and consideration in managing patient with multi-aneurysm should be considered. This case emphasizes the importance of precise preoperative planning, including therapeutic anticoagulation and detailed imaging to ensure successful outcome in such challenging scenarios. The role of conservative management for smaller asymptomatic aneurysm, as well as the use of advanced endovascular technique when appropriate. Maintaining high index of suspicion is critical for ensuring timely therapy in the form of open repair or percutaneous intervention, both of which are approved strategies. Thank you.